spending the next 1 hour or maybe less talking about chest pain in children. You'll be encountering it in your OPD, whether you like it or not. Your passion may be cardiac catheterization or echo or whatever it is, but whether you like it or not, you'll get enough cases of chest pain. Boring, not really. You have learned in your MD Pediatrics that 95% of the time it's non-cardiac, but we are here to talk about when it is cardiac. So when a patient comes to you as a referral from a pediatrician, remember it's being sent to you as the first and the last stop. Somebody's had chest pain, they've sent it to the pediatric cardiologist, now it's your job to do justice. You need to make two lists of differential diagnoses while dealing with the chest pain patient. One, which is most commonly referred to, which is the most likely to occur. So whether it is pleuritic chest pain or it is musculoskeletal, whatever it is, that is one list you prepare based on your history. And the second one is where the reason for the chest pain is something very, very vital, although it may be rare, you just cannot miss it, and therefore it's important to actively rule it out. What kinds of chest pain do we get excited about? Number 1 through number 10 is one which is exertional. Whether the chest pain happens during exercise or after exercise. Somebody who's finished his games period, but then 15 minutes later gets chest pain still, should raise a red flag, and you should give enough respect to that, and it earns definitely $1 million workup. Any chest pain that is associated with syncope, palpitations needs a workup. The location of the chest pain, well, children usually cannot describe it to you very well. Severity, what I like to use even with the 7-year-old who comes to me with chest pain is the 1 to 10, where I tell them what 1 means. That means hardly any pain, and 10 means the worst pain ever. So what do they think their pain is? Is it 5 or 6? That works pretty well even with a 7-8-year-old. They're able to tell you well pretty consistently. You can ask them the same question repeatedly during your encounter. But they're not really good differentiators to tell you whether it is cardiac or non-cardiac. Of course, if it's something like a history that is fitting, one with fever and cough and cold, and you have chest pain, or one where there is trauma, or where it is in a adolescent girl right along the nipples. So there you have it's non cardiac chest pain, but otherwise it's exertional chest pain or any other cardiac symptom where you need to work it up completely. So approach begins with the history, a very detailed history about the chest pain will get you a lot closer to what the real diagnosis is. It certainly isn't all about the echocardiogram. An accurate ECG interpretation is a must. So while we're going through the next the remaining part of the session, we will be stressing on the importance of history taking, which will get us to the importance of pre-test probability, where your test is the echocardiogram. So before you begin your echocardiogram, what are the chances that you're going to encounter a cardiac defect of whatever kind, inclusive of something in the pericardium, or some abnormal pressure, or an abnormal valve, or a coronary artery, or the wall thickness, whatever it is. What is your pre-test probability? That alone can minimize a thought about the pre-test probability can minimize chances of you having a false negative echo, which is the last thing that you want. While going through the cases, we'll pause for a bit looking at the cardiac enzymes. We'll look at the STT changes all through cases. So the first case is rather simple. This is a 10-year-old boy who shows up in your OPD. The child is on AKT and he's come in with severe chest pain. He's been under the care of a pulmonologist who's been giving him treatment for cough. The doctor is not really happy with the response, and now for 1 week he's got edema of the feet, which you confirm, yes, it is there, and yes, it's fitting, ruling out thyroid kind of edema. There's no steroid therapy started yet. So when you begin to do the echo, what is the pretest probability of having a positive test? What are your thoughts? 10-year-old on AKT with chest pain and edema. So edema is actually another pointer that this is the heart, which is the cause for the chest pain. Chances of us finding something are pretty high. I think we're all very much aware of constrictive pericarditis that is common in patients with cough. So what you are looking out for is, of course, the echogenic pericardium, but many times it's echogenic in many of our patients without the constrictive pericarditis. So you have to dig a little bit deeper. What will help for one is an M mode. M mode tracing, like here at the bottom of the picture. This is diastolic point, when there is the wide separation between the posterior wall and the septum. This is the systolic point. This is early diastole and then later on. When you start seeing these peaks like these, this is called a septal bounce, and it's basically due to the pericardium enclosing the ventricles like a rigid sac, not letting them distend the way they want to while they are filling. That causes the septum to shift in one direction and shows up in M mode, because M mode has such a high temporal resolution, it's able to actually capture it as a bounce like this. If you see something like this in the setting of a clinical situation where you are suspecting constrictive pericarditis, maybe if there are some other echo clues and you see this, then you can start assuming this is constrictive pericarditis and perhaps get yourself a CT scan as well. What will help on the Doppler imaging, mitral inflow, is the pattern where it shows that your filling of the ventricle is disturbed. Your E wave, which reflects the early diastolic filling, is very, very prominent. The slope is very, very sharp, and the A wave, which reflects the late diastolic filling, is much shorter. So your EA ratio absolutely jumps up to more than 1.5:1. You can also measure the deceleration time from here to the time it gets to come down, the slope reaches the baseline. And a combination of these factors will get you to your diagnosis of constrictive pericarditis. A whole lot has been written about how important it is to differentiate between constrictive pericarditis and restrictive cardiomyopathy. In my limited experience, the clinical history helps us differentiate a whole lot. Secondly, in whatever the restrictive cardiomyopathy cases I have encountered, the atria have been way out of proportion in size compared to the ventricles. You take one look at your apical four-chamber view, and the atria are so much larger than the ventricles. And you correlate with your historical picture, and you can come to a diagnosis. Obviously, you can of course refer to your text, pull out the table differentiating the two, and see how many points you can cover effectively. Not an easy thing to do. Time consuming, but obviously has to be done when it has to be done. You also have your cardiac catheterization that you can do in such cases. So this particular child with constrictive pericarditis, we got a CT scan which confirmed that yes, this pericardium was thickened, taken to the operation theatre, a pericardectomy was done, patient then completed his AKT course and recovered uneventfully. Next, looked at a 10-year-old girl who presented to our pediatric cardiac clinic with exertional chest pain of increasing severity for the past few months. The father was ignoring it all the while, but then when it became more severe to the point that she had difficulty walking to school, he decided to get the child to us. This pain was relieved after resting. There was no palpitation and there was no pain episode at rest. So this is a case of exertional chest pain, and this should get you really, sitting up in your seat when you encounter such a history. We dug a little deeper into the quality of chest pain, and there was heaviness in the left chest associated with feeling out of breath. Pain scale, she said, 7 out of 10. And when you're doing this, you are also asking the girl or in this case, the father. So who else is there in the family? Is there a grandmom who has similar symptoms? We're trying to determine if this girl is copying. You're copying her grandmother, just imitating her for the fun of it. And you're asking the father, what kind of girl is she? Is she the kind who would do this? You're analyzing everything. You're also asking to see, well, does it happen when she's doing something she really enjoys, maybe skipping? And if it's happening even when she enjoys things, to believe it. So there are a lot of things that you are analyzing, internalizing at a single time. There's no history of trauma to chest in this particular case. No history suggestive of a connective tissue disorder going on, no pre-syncope or syncope. Now, this girl turns out had been to a pediatric cardiac clinic before elsewhere, and a diagnosis of mild supravalvular aortic stenosis was made when she presented chest pain there. This was 2 years ago. At that time, she had a murmur as well. The report said it was mild with a gradient less than 40. And supravalvular aortic stenosis, people, at that point worked it up for Williams syndrome, got a FISH test done, and it was negative. So now you have this 10-year-old with supposedly mild supravalvular aortic stenosis with exertional chest pain. But the report was from 2 years ago, so has it worsened? Is it very severe now? Is that the cause of the chest pain? Should we get the echocardiogram? Of course, we will get the echocardiogram, but prior to that, it's essential to ask for some more history and examine the kid. So past medical histories, that of no hospitalizations, no history suggestive of rheumatic fever, Kawasaki, or collagen vascular disease. The father then tells us, you know what, the older sister had similar complaints and expired undiagnosed at the age of 5 years. That was some 5 years ago. That's dangerous history, isn't it? On physical examination, this is what we find. What are these? Does anybody want to guess? You see these little protuberances, they look a little white, and we also saw them on her knees and even around her nails, her toenails. Xanthomas. These were xanthomas. So apart from the murmur that we heard, which was pretty harsh with a bruit, we had these xanthomas. When we did the echocardiogram, it showed us mild supravalvular aortic stenosis, nothing beyond. This was the X-ray. So nothing that caught my eye here actually. I saw the normal cardiac fluid, didn't find any atrial enlargement, heart size was normal, lungs looked okay. And I always do the cardiac part of the X-ray reading after I've done the abdomen and bones part. My teacher used to say ABC while reading a chest X-ray. So A is for abdomen, look for the stomach gas on the left side, the liver here. Look for the bones, any fractures, anything unusual. Look at the vertebral column, any hemivertebrae, anything, telling you anything congenitally going on. Then focus on your chest. So nothing, interested me here. We got an ECG. So we see that the speed is standard. The standardization is also standard. and we look to see how things look. Begin with the P wave here in lead 1, lead AVF, both positive. Sinus rhythm, heart rate is all right. Then what else? Well, inverted P in V1, normal for a 9-10-year-old. V2 also inverted. What else? Well, axis positive in 1, positive in AVF, so that's fine. But what else is happening here? Look a little closer. You've got perhaps ST segment depression there, like an upsloping one in lead 2, AVL. Lead 3, this is actually 3, it's showing elevation. AVR, it's showing elevation. Look at these leads, the precordial leads. Depression here in V2, depression in V3, V4. So something's going on. Let's pause for a bit here and talk about ST segment depression. You know, the adult cardiologists do it all the time on a daily basis. They are analyzing ECG. For us, it happens once in a while. At least now it's happening once in a while. As our OPD becomes more senior, meaning that we have a bigger population of corrected children who grow up into adolescents and adults, we'll be forced to encounter chest pains and ECG and adult type settings. So obviously you will be big buddies with your adult colleagues, and you will also want to, however, have some idea of how to interpret the ECG in case of ischemia or infarction. So when you look at ST depression, you're looking at actually ischemia for the most part. What you need to know is your J point. That's when the QRS ends. And the ST segment depression may be of 3 types. It may be upsloping or downsloping or horizontal. Horizontal is something which is absolutely abnormal, but these are also abnormal. You need to measure the ST segment depression 2 small squares after your J point. And the amount of depression should be half a small square. Anything beyond that is significant. So going back to our ECG, look at this over here. You've got your J point, you've got a downsloping, and certainly it is significant in terms of beyond 2 small squares after the J point. You have it low down, definitely more than 2 small squares than the 3P line. Similarly in V3, when you see something like this, ST segment depression, V2, V3, you've got it in 1, you've got it in 2, and it's of different morphologies. Here it's straight, like horizontal, here it's upsloping, you have it downsloping here. This may mean serious things. And if you actually, try and correlate, pick up a textbook, it actually tells you that this is typical for left main coronary artery occlusion, which I also learned later. At this point, I recognized that there was a significant ST segment depression changes, ischemia going on. More commonly, for infarction, you have ST segment elevation, where again, from the J point, you actually measure the ST segment elevation at the J point, and if it's more than 1 mm in 2 contiguous leads, by which I mean 2 leads representing this same anatomical area. For example, 2-3 AVF would be inferior area of the heart, or 1 AVL would be the lateral. The precordial leads would be the anterior wall. So those would be contiguous leads. So if you have an ST segment elevation at the J point of more than 1 millimeter in contiguous leads, 2 contiguous leads, that's considered significant. If you're looking at V2, V3, then you actually need for them to be a little bit the elevation to be more than 2 mm, which would be 2 small squares. So depending on where the ST segment is elevated, you can kind of localize the infarct, something that our adult colleagues do all the time. If it's in the precordial leads, V1, V2, right next to the sternum, it's going to be enteroseptal. So precordial leads is all anterior. If it's close to the sternum, it's septal. And if it's at V5, V6, that's lateral wall, and it's V3, V4, it's enteroapical. Lead 1, lead AVL, what we see very typically in our L kappa cases is lateral infarct, and 2, 3 AVF is inferior wall infarction. Look at this adult ECG I have for you over here. It says heart rate 60, standardization is normal. T wave upright here, so sinus rhythm. You've got AVF going down, QRS going down in AVF, and you have AVL positive, 1 positive. So left axis deviation. What else are you seeing? Well, you've got some ST segment elevation here in 2, also 3, also AVF. So you've got significant ST segment elevation, more than 1 small square here in contiguous leads. So this is like inferior wall infarction. You've got a reciprocal change in AVL. So let's go back to the girl with chest pain. Remember, she's the one who had ST segment changes of varying morphology in the anterior leads and also in some of the limb leads. She had depression. We saw that the echo showed just mild supravalvular aortic stenosis. So we went ahead and got the cardiac enzymes done. The CPK-MB was 44, the higher limit being 24 units per liter. We also got a troponin I. The result came out as 2, seems very small, but actually look at what the normal limit is, 0.02 nanograms per ml is considered high. So we had elevated enzymes. What about them? Well, I'll take you through 2 graphs. Hopefully this will make us all very much more comfortable interpreting them and their values. So here is the time since your damage to the myocardium, and here is the cardiac marker concentration. Look at the orange line. The orange line shows the CPK-MB tracing. It says that it starts to rise by around 12 hours after the event. It peaks, you've got the highest level, and then after 1 day, by 2 days, definitely your CPK-MB normalizes. So if you were to do the CPK-MB 1 day after an event, your level would be only mildly elevated. As against that, if you look at the green and the blue lines, which are troponins, those also rise very rapidly, but a little delayed. The CPK-MB rises a little bit earlier than the troponins, and the degree of elevation here for a large infarct is many times normal for troponin. Then the first day, late after 1 day it falls, but still remains pretty much higher. This is 50 times normal level, let's say 50x, that's 100x. So the troponins remain elevated for the longest time. If on day 2 you're doing CPK-MB, you are likely to get them to be non-elevated. But your troponin will continue to be high, abnormal. So why don't we just do one? Why do we do both? Why do we do CPK-MB and troponin when both of them are released from within the myocardial cells? Well, the advantage of combining both is that we can catch the small infarction. So here, this line here is the troponin level in a small infarction. So it's only very little bit elevated. The level is abnormal, but not very abnormal. While your CPK-MB is elevated, 4 times that the normal value. So you will catch that if you do both. And also, if so, what I'm saying is if you do it you do just the troponin, you might be fooled if it's only very mildly elevated, but you will catch it if you do the CPKMB. And if you're doing the test really early, then chances of you getting the CPKMB positive is high, while your trop may not have started to rise as yet. Obviously, you'll do serial value monitoring. Um, but what I'm trying to tell you is that there is an advantage in combining both of these tests. And in this day and age, obviously, it doesn't take time as well. You've got those spot tests you can do right in the casualty. So then what do you order? Do you order T or do you order I? Troponin T binds tropomyosin, troponin I binds actin, troponin C binds calcium. You remember from your physiology, cardiac, the whole contractility thing, how the chains bind to each other, actin, myosin, what goes on inside. We're looking to measure the levels of these troponins which are released. It's just that Trop T has been studied more. So if I want to get one, I choose T. Troponin T, you can actually have a quantitative analysis done. So a healthy individual will have this kind of level in nanograms per liter. Subclinical disease, also your troponin T will remain normal. Then it goes on, from 0.005 to 10 times raised in micro AMI, and then 200 times raised in small myocardial infarctions, and multiple hundreds of times of normal value in the large myocardial infarction is what troponin T quantification helps us with. Going back to that girl, remember she had elevated troponin I level and CPK-MB. We got a cholesterol panel done because of those xanthomas we saw in her, and also because of her family history, the sister having died. And as expected, her total cholesterol was very much elevated, 900 units. Her out of that LDL cholesterol was close to 600. So what she also had an abnormality of the apolipoprotein B. The atherogenic kind of cholesterols are right here versus the ApoA, HDL, the anti-atherogenic one. So all of these were elevated for her. And she had the familial homozygous kind of hyperlipidemia. The heterozygous hyperlipidemia is fairly common, but homozygous is rare. We went on to check her siblings. She had two sisters and also her parents, and all of them had some degree of hyperlipidemia. I think her mother was most affected amongst the 5 of them. She was started on appropriate diet, statin, low-dose aspirin therapy, but what about her chest pain and the enzymes and ST changes? We went ahead and got a CT scan done. Now that showed, obviously with the intention to study the coronary arteries, we had to give beta blockade to get the heart rate down low so we could see those properly. It showed there was a soft plaque in the left main coronary artery causing moderate to severe stenosis. It obviously picked up the mild supravalvular aortic stenosis as well. So that's it in 3D, that's the origin, and narrowing over here. So we talked with the father, finally got an angiogram done that confirmed the stenosis, and we debated about what to do. The fact that she was growing, that her left main wasn't the adult size, the fact that this wouldn't be her first or her last kind of stenosis or intervention, and the fact that if you put in a regular metallic stent, then there's a potential for late onset thrombus. We also considered surgery, but again we knew this wouldn't be her last stenosis. This was a condition where she would be probably facing multiple such events. So, and being in a growing age, we decided to use a bioreabsorbable stent. A bioreabsorbable stent, at the end of 30 days, the black metal part looks like this. not the metal part. The material looks like this. 90 days it's like this, 180 days, and at the end of 365 days you see so little of the stent is remaining. The polymer gets absorbed. So she underwent placement of that, improved symptomatically. So now this is close to 1 year, 1.5 years post the event. She's doing well, although her cholesterol is still very high. I'm debating offering her plasmapheresis. Yeah, there are other anti-lipid lowering agents available, but they're extremely costly right now. We did get this case report published recently in the Cardiac Catheterization Intervention Journal. So had we not delved into the history or just done a cursory exam, we could have just done what the pediatrician requested, which was to do an echocardiogram, written that this showed mild supraortic valvar stenosis and sent her back. But what got us to the right diagnosis was just doing the whole thing properly in a systematic manner. So the complete history, including the family history, the complete examination. So once you have that family history, you obviously now are hopefully looking out to see xanthomas. And then you put 2 and 2 together and then do the whole thing. So even if your referral doctor has asked for an echocardiogram, you simply pick up the phone and explain to them why getting an ECG and whatever it is that you're doing is absolutely the right thing to do. There's absolutely no excuse for just doing the echocardiogram and giving the report, sending the patient away. Let's move on to the next case now. This is an 11-year-old boy. He presented in a collapsed state to our emergency department for the first time to us. What had happened was that he had come home after playing cricket with his friends, regular cricket, day cricket, collapsed 15 minutes later and was rushed here. He was in shock, non-paratable pulses, in bilateral creps. Heart sounds were normal. Heart rate was 150. Went into VTAC rapidly, received CPR, cardioverted, and basically got everything. Intubated, transferred to the ICU, started on inotropes. We sent off the labs, got an ECG, got an X-ray, and meanwhile we got a chance to look at the past medical history, talk with the parents. Differently, he's been having chest pain of around 7/10 severity 4 months prior to this presentation. At that time, the ECG had shown some ST segment elevation in multiple leads. At that time, cardiac enzymes were done. CPK-MD was around 100. Trop-T was positive. They did serial analysis, and 3 days later it was 31, so marginally high. X-ray was normal, fasting lipid profile was normal, an echocardiogram was also done 4 months ago that was reported to be normal. An exercise stress test was done which was reported to be normal. So imagine this patient comes up to the OPD 4 months prior with a history of 7/10 chest pain. They see the SCPs, they get cardiac enzymes, they find them elevated, not very elevated. Serially, they follow up, they find them touching normal then. They get a lipid profile normal, echocardiogram normal, stress test normal. So then what happens? They're just dismissed. Patient goes home. They even got a Holter test which was normal. So after all this workup, 4 months prior, he continued to have mild episodic chest pain associated with exercise, either during exercise or after. And then he presented in collapse to us. No other illness, a healthy child otherwise, never hospitalized. Big shock to the family. Has one healthy sibling, studies in the 6th standard, good student, with an average interest in sports, stable home environment, nothing where you start thinking, is he in the wrong company, does he have access to drugs, something going on that you don't know, some case of ingestion of some other toxin, nothing like that, no leads there at all, and nothing in the family as well, sudden cardiac death or coronary artery disease prior to the age of 55 years, also not there. No unexplained death, no death at young age. So what do? We get an ECG, which I'm sorry I don't have it here to show to you, but it basically showed significant ST segment depression. So we can revise what significant ST depression means. It means we are looking at the QRS complex, we are locating the J point, we are moving two small squares, which is 0.08 seconds away from the J point, and we are seeing how much is the ST segment depressed. Any depression of more than half a small square is considered important. It should be in two contiguous leads for you to get a pattern, and by that I mean in leads which represent the same anatomic area, for example 2, 3 AVF or 1 AVL or the precordial leads. So this particular ECG showed widespread significant ST segment depression. X-ray was normal, although the lungs were congested, denoting pulmonary edema. So now we were ready for the echocardiogram, and so far what was going on in our mind was that this is something cardiac. Exertional chest pain with elevated enzymes, abnormal ECG showing ischemia means cardiac. So, oh, and yes, the ABG showed metabolic acidosis. Cardiac enzymes were abnormal, so echocardiogram. We noted that the left ventricle, left atrium were dilated. There was global LV dysfunction. Anyone who's had VTAC, who's had CPR with metabolic acidosis is going to have some dysfunction and dilatation. We focused on the coronaries, and we wanted to show a normal coronary artery origin of the right and the left coronaries. We could not. We saw that the left coronary artery origin was abnormal. The LMCA was arising from the right side of the valsalva along with the right coronary artery. And once it did that, it had an intramural course and was coursing posteriorly and getting compressed between two great arteries. This is your standard parasternal short axis view. You're supposed to normally see the RCA originating at around 11 o'clock position with around 3 o'clock giving rise to your left coronary artery. We didn't see anything there, although it's easy to have a whole lot of artifacts and things that you may take to be the LMCA. But remember, here we were not ready to back off until we were absolutely convinced, which means putting it in color, getting the scale down to 15 and seeing for color in whatever, long shadow representing a coronary artery we could see. So it was after, a persistent, diligent look, we were able to figure out that the left main was arising from there. And basically the eyes only see what the mind knows. So you need to have your list of cardiac causes of chest pain, run down the whole list and figure out, yes, there's an entity called the suicidal coronary artery which can present like this, and you actually have to rule it out along with all of the other lists in that cardiac list. So they're making it a little bit more clear. Single ostium, RCA, giving rise to the LMCA running between the walls, in the walls of the pulmonary artery and the aorta before moving out. Here's a pictorial. That's the LAD, that's the circ going down. So we did a CT coronary angiography there in the middle of the night, confirmed the findings, showing that the LMCA had an anterior origin. The patient continued to have ventricular tachycardia, not responding to medical management, was placed on IABP and then rushed to the operation theatre, underwent emergency coronary artery bypass grafting. So they put the graft distal to where it would have been compressed by the great arteries. He was placed on ECMO post-bypass, but unfortunately he didn't make it. Anomalous origin of the left coronary artery. So it doesn't always have to be the pulmonary artery. It doesn't always present at 4 months of age. This is the other kind of anomalous origin. Pretty rare, and presents as early cardiac death, especially during vigorous exercise in adolescence. Obviously, this child has had it since birth, but till now he never really exerted himself that much that his cardiac output increased manifold during exercise, distending the aorta and the pulmonary artery and compressing the coronary artery in between. Chest discomfort, atypical chest pain, syncope are the most common presenting complaints. So you do the resting and the exercise ECG. They are important but not a reliable screening test. A stress test. Remember, this child had a stress test. So what happened over there? Well, we looked at the complete report, and turns out that he did not meet his peak heart rate. Whenever you do a stress test, for the machine and for you to interpret it properly, you need to make sure that your child exerts himself so much that his heart rate shoots up to what it should be, at peak exercise. It's determined by your age and your, basically there's a simple formula. It tells you what's the peak heart rate for that particular age, boy or girl. So turns out he didn't meet it. Means it was he didn't stress himself enough. So therefore, it was incorrectly reported to be normal. While the truth was he never ran on it as much as he would have perhaps exerted his heart when he was playing cricket. Echo once again, the pretest probability in this case going in was very high for detecting something or getting something positive on the echo. And we looked extra hard and found it. But CT scan is the gold standard. So the mechanism is ischemia, and that's because of the acute takeoff of the anomalous vessel, the slit-like orifice, which itself is abnormal, the intramural course, all contribute to ischemia. So clinical identification in a timely manner is critical. And surgical management is indicated in all patients with actual coronary insufficiency. Incidentally, around 1 year after we had that case, on a routine echocardiogram on a 2-month-old, we diagnosed this. We saw that the left coronary was originating from the right sinus and passing that way. So a 2-month-old is a lot different from the 14-year-old. So at that point, we, talked with a lot of care to the parents. The idea is not to get them into some kind of psychosis where they are unable to sleep at night because of this diagnosis, because it's not going to do anything at that point for the 2-month-old. So the idea, we talked with the pediatrician, with the family, and we decided we'd be following it up, confirm it by echocardiogram again in a 6-month year or so, and then at some proper time get the CT scan and follow it up until we were all very comfortable that this is the right time to go ahead and offer surgery. We certainly did not rush into suggesting reimplantation surgery for the child infant at 2 months of age. There is a possibility of genetic link, and therefore screening is recommended by the book. So we've gone through 2-3 cases so far. Look at chest pain in this 10-year-old boy. This happened to be an inpatient, actually a recent case, was admitted with a physician for pyrexia of unknown origin, was on AKT. We had diagnosed COX, which is a quite common thing to do in the developing world. Whether or not we have, we are entirely convinced it's COX. Many times patients are placed on AKT. So here, the physician to which ultimately this child was referred to and admitted was not satisfied with the diagnosis of COX. ESR was 80, CNCA was positive. And while being admitted, while all this inpatient workup was going on, the patient developed chest pain, very severe, very sudden in onset, retrosternal, and he had no history of prior such chest pain. ECG did not show anything. So echocardiogram. Well, This time we were actually thinking of pericardial effusion, pericarditis, things like that. And yes, we did find pericardial effusion. But as we were making our normal views, normal windows, we noticed that there was an aneurysm at the LV apex. The aneurysm was such that actually it had, the muscle wasn't there, it was perforated, and there was a pericardial effusion there. I don't have the echo to show it to you because my clip isn't working. But what I have here is a CT scan that was done that showed the outpouching. We've sent off a biopsy, and there is some vasculitis suspected. Something very, very rare, but chest pain vasculitis presenting like this. This is the option. That's the leg end. Here is your aneurysm, which we are isolating. You will shortly see it removed and sent off for biopsy. There you go. That's it. Let's now generalize a little bit, and our 1 hour is almost up. Cardiac causes of chest pain could be due to increased myocardial demand or decreased supply. Cardiomyopathy is pretty common. It is easy to pick up on echocardiography, whether it's the dilated kind or the hypertrophic kind. A differential that a lot of people abroad, cardiologists abroad, have to deal with is the athlete's heart. So there is a clear set of differences between a hypertrophic diseased heart versus an athlete's heart, also showing thickened myocardium. Another cause could be aortic stenosis or sub or supravalvular stenosis. Arrhythmias is a big one. So in that case, you will have a history of palpitation and wear a Holter monitor, or a cardiac event recorder is recommended. Event recorder is much more preferable. Another cause of chest pain, like we learned, is coronary artery abnormalities, whether it's L kappa or the left arising from the right sinus, or a fistula. You could have acquired causes, whether it's Kawasaki with aneurysmal dilatation of the coronaries, or post-surgical like an arterial switch operation, or the Ross procedure where your coronaries may be abnormal. Post-transplant coronary vasculopathy is something you all will be encountering more and more. The number of pediatric heart transplants in India has suddenly shot up in the last 1 year. Our team has done around 8 so far. And the most common cause of death for pediatric heart transplants is post-transplant coronary vasculopathy. It's accelerated, and there's very little that can be done. We do place them on statins, but there are conflicting reports on whether they actually help or not. There are a couple other drugs available, but this is something we have to deal with. Our most recent encounter with chest pain in a post-transplant patient was in a 14-year-old patient who received a heart 1 year ago because of cardiomyopathy related to non-compaction. Everything was uneventful. He underwent his 1 year biopsy, which was reported to be, which was normal. And 1 month after that biopsy, he came in with severe chest pain, to the extent that he was hyperventilating and little tachycardic. We gave him morphine, gave him oxygen, got the 12-lead ECG, which showed not much abnormality. The first thing we did was compare it to his prior ECG from a month ago, so it was the same. We sent off enzyme shift to raise, and prior to that we did an echocardiogram. which showed biventricular dysfunction. So it was rejection episode, acute rejection presenting with chest pain. He is at present undergoing therapy for the same. Another acquired cause is, of course, hypercholesterolemia, which we saw a case of. Pericarditis is pretty common, myocarditis, and then you have causes like aortic dissection or rupture of an aneurysm. Pulmonary hypertension is a very big one. You are doing a evaluation of chest pain. You got some pointers that it is cardiac. You do an echo and it is normal. Because of your historical markers, maybe you know it's cardiac, then don't please just stop at saying echo is normal and no further workup needed, because you haven't ruled out pulmonary hypertension if you've not had a TR jet to give you the RV pressure. So many times we don't get the TR jets. So does that mean there is no pulmonary hypertension? Of course it doesn't. You may have severe pulmonary hypertension. The RV may not look outstandingly abnormal, and you may miss it if you don't have a TR jet to measure your gradient. At that point, you need to make sure your pulmonary veins appear normal. And the other thing you do is do all that the ACC says to do when you suspect a child with pulmonary hypertension. It gives you things to do with the pulmonary valve Doppler, pulse Doppler, measure time intervals, measure slopes, any indication that something is wrong, that the pulmonary pressure is high. Then what is warranted next is a study of the lungs and of the pulmonary veins by a CT scan, and then maybe a cardiac catheterization. What I'm trying to get at here is, if you have a chest pain which you think is cardiac based on your history or clinical examination, you cannot just stop at echocardiogram. You need to move further with either a stress test or a CT scan or a cardiac cath, whatever it takes to get to the diagnosis. A cardiac cause, if suspected, you have to rule out everything on the list. We have also seen chest pain in a girl. Well, this particular patient was a girl, 14-year-old girl, previously healthy, presenting with severe chest pain. And the ECG was normal. The echocardiogram showed a significant mitral regurgitation with ruptured chorda. So this wasn't a case of congenital mitral valve prolapse. Most likely, actually, this was a rheumatic acute rheumatic carditis. So that also comes up in your differential, but fairly easy to pick up on echo. What really tests us is when the echo is seemingly normal and you have to use other resources to get to the answer. Don't forget cocaine or other overdose. So I'm going to end over here, and I'm ready to take questions if you have any.